Hello everyone, welcome to the Head Foundation. I'm C.D. Liang. I work here at the Head Foundation. I just want to do a brief introduction before we start our talks. The Head Foundation is a non-profit organization based in Singapore. Our mission is to improve lives in the region through education and healthcare. So in essence, we provide grants, we support projects, we coordinate projects to bring effective healthcare and education solution to underserved communities in the region, mostly in Southeast Asia, in countries like Indonesia, Laos, Cambodia, and so on. So today, obviously we also do a project on awareness on solutions. So that's why we organize talk like this. We publish magazine. There's some magazine outside you can pick up if you want. And our strategy is to bring East and West solution to try to bridge or facilitate between traditional wisdom and innovative technology, especially those from the Western Hemisphere. For example, we bring traditional Chinese medicine to top Western hospitals in the US, in Europe, so that we can have the Western doctors and the TCM practitioners to work together on solution that's more holistic. Hopefully we can help more people, especially when a society is aging. And also, that is why we brought you today's topic, because there are a lot of people with pain issues, and pain management is something that we have been working on, right? For example, we are trying to bring traditional medicine twin-hour solution in TCM, right, to help in some of the chronic pain. So today we have two speakers, Dr. Diana Chen, who is a pain specialist based in Singapore, and we also have Professor Andy Hsu from Shanghai, I guess, and Australia. You have their profiles in the invitation, so I'm not going to waste time to read their profiles to you. I'd rather give more time for them to share their knowledge with you. And please, if you haven't done so, turn off your sound on your mobile phone so that you won't interrupt the talk. Each of the speakers will speak for about 30 minutes. You can save your question to the end because we have about 20-30 minutes for Q&A after their talks. Thank you, and let me invite Dr. Chen to deliver her talk.
Thank you for having me speak here, and I think my introduction was flashed on just now. And so I'm actually a private pain specialist, and previously I was heading the Department of Pain Medicine in Singapore General Hospital, and I also founded the SingHealth Duke-NUS Pain Center, which united the different hospitals from the SingHealth cluster. So without further ado, I'm going to go on to my next slide. So this is my agenda for today. I understand that most of you here are either physiotherapists and traditional Chinese medicine, acupuncturists, any other specialties or medical practitioners that are here that may not be may be part of like maybe Western medicine, or maybe other people who are from different sectors here. Or most are healthcare practitioners already. Okay, everybody's very shy. Okay, never mind. I'm also quite shy, but okay, can. So I'll just go through a little bit on the definition of chronic pain, the common pain conditions that we see in adults, what the pain clinic does, and what our role as pain specialists do, the general principles of pain management, and how we also often use complementary therapies and adjuncts to help with our chronic pain patients. Okay, so International Association of the Study of Pain is a well-known international organization which aims to unite the different countries together with its role and function in managing pain. So pain is described as an unpleasant sensory and emotional experience. So we recognize that pain itself is not objective. Okay, it's not. If you have managed patients, you would actually understand that common pain pathology may generate different pain responses in different individuals when due to their underlying social circumstances, experiences, and so it encompasses an emotional and a distressing experience, which often is related to the patient's psychosocial background. And so it has described pain that it can be associated with actual potential tissue damage. It may not associate with actual tissue damage, and it's associated with sensory, emotional, cognitive, and social components. Okay, so there has been a lot of changes in the definition of pain since 40 years back, and so the latest one is the 2020 year 2020 revised definition of pain notes, and it recognizes that pain and nociception is the objective sensation of pain due to injury, are different phenomena, and it cannot be inferred solely from activity in sensory neurons. So individuals, through their life experiences, learn the concept of pain, and this is why it is very important that we individualize pain management according to the individual and their experiences and their upbringing. Going back to the basic science and the pathophysiology of pain, this is a very simple diagram to describe acute pain. Now, acute pain is a lot easier to understand for scientists, for practitioners like us, because it is a cause and effect kind of phenomenon. There is a tissue injury, it causes inflammation, and at the nerve receptors, we release mediators like substance P and prostaglandins. And then the nociceptors results in a transduction of the signal to the spinal cord and up to the brain. And we have different modulating pathways, both ascending and descending pathways. And then this tells us that our body is in pain. It is a protective mechanism. It tells us that the body is exposed to something potentially dangerous, and we move away from the source of pain. For example, like when you touch a kettle of hot water, our basic instinct is to move away, because this is the mechanism that is in place to protect us from further tissue damage. Because if we don't move away, the next result would be burns and scalding of the skin. Okay, so there are three types of pain fibers. Two types of pain fibers, A delta and the C fibers, that are responsible for both fast and that one is fast conducting and one is slower conducting. So it results in a first experience of pain, and then after that, you might actually feel that when there's a tissue injury, you might first feel a sharp pain immediately, and then the pain actually changes, the sensation of pain actually changes. So this is due to the two fibers that work in place. And why this is important, because it is important for the next thing that I'm talking about, the gate control theory. Why does massage tuina helps to alleviate pain? Why does, even in terms of acupuncture, there is also postulation of the gate control theory being involved in the mechanisms of acupuncture. Okay. For the acupuncturists and the traditional Chinese medicine practitioners, this may not come up in your meridian theory. I also have a graduate diploma in acupuncture, and so I know that I never studied this in my GDA. But in the Western medicine, this was what postulated for tuina and acupuncture, in that when there is a C fibers that is transmitted, and when we do massage, the A beta fibers, which is responsible for touch and vibration, is actually activated and closes the gate to further transmission by the C fibers, and therefore this transmits to our brain and relieves the pain, because our C fibers is inhibited from firing further. Okay. So as I said, there are many ascending and descending pathways, and it is shown in the animal models that with ongoing stimulation of the ascending pathways of pain, which transmits the signals to the spinal cord and the brain. The brain also modulates by sending signals down different descending pathways to modulate the pain. When it's continuous, there is a concept called central sensitization and peripheral sensitization, leading to increased experience of pain. And this is why for some people who have had chronic pain, they may be a lot more sensitive to further stimulus or pain generating activities. Okay, so I deal with a lot of chronic pain patients because for pain practitioners, by the time the patient comes to us, it's been about 3 to 6 months after they experience pain. And this is something that is quite close to my heart. And usually when chronic pain occurs, it's not just due to a pathology itself, but there are already neuroplastic changes within the body. And this results in what we call neuroplasticity and cortical organization. And this is also influenced by different coping mechanisms to pain, the presence of depression and anxiety, which also which are also the emotional center in the part of the brain is also responsible for the experience of pain. So this results in a very, very different experience of pain altogether, leading to what we call the vicious cycle of chronic pain. Okay, these are some of the common chronic pain conditions that we see in the pain clinic. So in Singapore, musculoskeletal back pain is responsible for about 80% of our pain patients because we are a first world country. We have a lot of, it used to be low back pain, very common because our older generation did a lot of heavy work when they were younger, and then this resulted in a lot of degeneration. Increasingly, we are seeing a lot of neck pain in the younger population. It's because of desk-bound work, chronic handphone use, and we see a lot of spondylosis and degeneration. Then there are other things like headaches, migraines, nerve pain issues, especially post-herpetic neuralgia. I'm sure a lot of you have experienced or seen patients who have had post-shingles pain that are very difficult to treat. Fibromyalgia is another condition where patients experience chronic widespread pain of unknown cause, and it's usually a diagnosis of exclusion. Okay, again, this was what I was talking about, the chronic vicious cycle of pain, where there's presence of pain, then it's influenced by the patient's personality, underlying psychosocial factors, resulting in anxiety that the pain is causing harm, catastrophizing, like for example, we tell ourselves that I'm not going to get better, or I cannot function because there is pain. This results in changes in the nervous system, leading to more anxiety, more avoidance of the movement. I'm sure the physiotherapists here will know that there will be patients who don't want to move because there is pain, but yet we know that this is counterproductive. Okay, so so this whole cycle that we need to break into. Okay, so what is the role of pain clinics and pain specialists? In the public sector, and I think a lot more is coming to the private sector, that we are responsible for coordination of the multidisciplinary care of patients with acute and chronic pain. Where do we get our referrals? We get our referrals from primary care, from allied health, and these are the common conditions that we see. From other specialties, for example, neurologists, rheumatologists, where they have exhausted their basic knowledge of pain management, and also from self-referrals when patients have the insight to seek help. And our approach is biopsychosocial. We look at the biological cause of the pain, the psychosocial factors, the socioeconomic class, the support that the patient has, and as well as the psychological behavior and approach towards their own self-management. And it requires a very multidisciplinary effort. So it's not just, no man is an island. We are not working in silos, but we work with everybody. And I'm not sure whether I've worked with any of the TCM acupuncturists here, because last time when I was in public sector, I worked a lot with my acupuncturists and my physiotherapists in terms of managing patients, especially with complex pain conditions. Okay, so these are the general concepts in managing pain. Usually we follow this framework, but every patient is individual, is different again. So we always want to target the root cause of pain if there is any, but often is not complete. Like I said, it's influenced by many factors. Okay, then the medical management will include medications, painkillers, injections or pain interventions. And we often work with our acupuncturists and allied health people in managing in managing pain. So these are some of the people that we work with. If there is a surgical cause for it, then maybe surgery is an option. And then a lot of time when our patients come in with chronic pain and they are complex, there's a lot of psychological work to be done. So cognitive behavioral therapy is one of the proven pain psychotherapy techniques in managing patients with chronic pain. And of course, there's another concept of cancer pain, which I think I will not talk about it today in view of the audience, yeah. Okay, so like I said, it's really, this is the psychosocial model of pain. We look at not just the pain intensity, but for biological, the nutrition, the sleep, the extent of tissue damage and disability. Psychological, we work with them in improving self-efficacy, self-esteem, and coping with pain. What happens when the pain comes? Do I call the specialist immediately, or do I go to emergency department immediately, or are there relaxation methods that I can do to reduce my intensity of pain at that point in time? We work with them on their we explore their perception. So really, pain is really a journey with the patient, a very long journey with the patient. And also we look at the social support. Someone who has had estranged family, not having a very complete family support would view pain differently from someone who has very good family support. Or someone who wants to take on a sick role because I want to feel the love from the family will have different pain experience from someone who is very secure about herself and knowing that, you know, I don't have to take on a sick role to gain love, so etc. etc. Okay, so I come to this part on pain interventions. It's something that what we do. So this is a very snapshot of what we do in the pain clinic. A lot of the times, patients come to tell us, when they are referred to us, they tell me they don't want surgery. So we do let them know that pain interventions is minimally invasive, and they are suitable for patients who have tried physiotherapy, conservative therapy for at least a period of 3 months with no or minimal improvement in pain or function, and those who want to avoid invasive surgery. The aim is to reduce pain, not to take away pain completely, because sometimes we cannot take away the pain completely, and to improve the function and improve quality of life. So compared to surgery, the risks are minimal. I would quote generally for most of the common pain interventions, as a less than 1% risk of infection, bleeding, and nerve injury. Minimal downtime. A lot of my patients ask me how long can they rest? I say you can go back to work the next day. And often tolerable with minimal post-op pain, and usually can be done under local anesthetic or even mild sedation. So what are pain interventions? They usually involve injections at neuroanatomical area of pathology, where the area of pain is. It may include steroid or local anesthetic injections such as nerve root blocks, epidurals, peripheral nerve blocks. It may include what we call radiofrequency current, which there are a few different types. A pulse radiofrequency current is it actually targets nerve and reduces its sensitivity without destroying the nerve itself. So the needles are connected to a radiofrequency machine and it generates heat. And this temperature is for pulse RF, is up to about 42 degrees Celsius with oscillating alternative current and direct current frequencies, and this does not burn the nerve at all. Then radiofrequency ablation is different from pulse RF. It actually burns the nerve, but so the nerve is ablated and the temperature goes up higher to 80 degrees Celsius. Why is it important? Because there are areas that are really innervated by nerves and it causes pain. And when we want to target pain relief, we need the area to be numb. One example is your trigeminal neuralgia. Okay, how do we manage trigeminal neuralgia? Often we see patients on high dose of nerve pain medications. This may affect their cognitive function, their memory, especially the elderly. So I've had a 90-year-old patient whom who told me that I still want to remain very conscious. I don't want to be so drowsy all the time. I think that the medication that I'm taking for the nerve pain is causing me memory loss. But at the same time, we know that trigeminal neuralgia is a very, very painful nerve neuropathy at the face area, and she couldn't eat. So what were some of the options that we gave her? Radiofrequency ablation was given to her. Later I'll show some photos. Okay, then and so they do offer better outcomes with prolonged neuropathic pain. These ablations, this is getting a lot more hype and commonality, and a lot of people who popularity for the last decade or so is for discogenic pain, no back pain with no with or without radiculopathy due to the disc degenerating itself. Sympathetic blocks, for example, your stellate ganglion, for chronic regional pain, complex regional pain syndrome, and chronic abdominal pain, as well as coccyx pain. I'll just elaborate a little bit further later. So these are some of the advanced and a bit more invasive pain interventions that pain clinics do offer. Vertebroplasties, for example, for patients with chronic compression fractures due to either cancer or osteoporosis. Intrathecal pump implants, these are for end-stage cancer patients who still have about 3 to 6 months more to live, but they are experiencing a lot of pain. And this is recommended for patients who are on high-dose opioids, where they want to reduce opioid use to try to remain a lot more alert at the end of their life. Spinal cord stimulator for patients who have had surgeries but failed back surgery syndromes, whom other things do not work anymore. And this is usually a last resort where we offer an implantable pump to generate like a TENS-like vibration to work on the gate control theory. And this actually inhibits the firing of the C fibers and the sharp pain that they experience. Okay. So biologics, I'm not sure whether anybody have heard of PRPs or platelet-rich plasma. I think it's gaining a lot of queries in my clinics and popularity. So it is there are evidence to show that it helps to the platelets taken from our own blood, when spin down to a rich platelet, consists of rich growth factors, and helps accelerate healing in tendon injuries, and joint injuries and ligament injuries. So yeah, and it is gaining popularity because it's very minimally invasive, it's quickly done, and the risks are very minimal. And people like it that, when we tell them that stem cells is taken from your own body, so there's no foreign substance injected. And yeah, it's all these things that, make it so popular now. Okay, so some pictures from what we do in clinics. So like I said just now, the disc injuries, how do I do this? Okay. Okay, so this is a biacuplasty, which is indicated for axial or discogenic back pain due to annular fissures of the disc. So we actually ablate the posterior part of the disc where there are nerve endings to reduce the pain that the patients experience. Sometimes when patients with discogenic back pain, they are in so much acute, sharp pain at the back that they cannot move. And this has actually shown very good results in some of my patients. And I work with certain physiotherapists for specific post-biacuplasties exercises to get the patients back back to their function. Okay, then nucleoplasty is another disc procedure, to which is indicated for radiculopathy, which is nerve pain due to prolapsed disc. Similar concept as well, it's just that the needles, what it does is that it decompresses the disc so that there is less compression on the nerve. Okay, so lumbar facet radiofrequency ablations. We know that the facet joints are easily, there's a lot of osteoarthritis, and sometimes they do experience axial back pain due to the facet arthropathy. Okay, then this is what I mentioned earlier, the trigeminal neuralgia, the Gasserian ganglion ablation, small needle injection in the face, and we actually test the patients according to their area of pain, and start a 60 to 80 degrees burn and cause numbing of the face and help with immediate, almost immediate pain relief. Okay, other other techniques that we have include sphenopalatine ganglion block, which is indicated for some of the cluster headaches, Botox injections for migraines, and for post-herpetic neuralgia, we also offer like interventions like intercostal blocks and thoracic dorsal root ganglion radio frequencies. Okay, so this is an example of a patient that I saw. She had her hand slammed on a door, and then she developed complex regional pain syndrome, causing like a difference in the color, and she has stiffness, and she fulfilled all the criteria for CRPS. We offered her a static ganglion block, and it was a workman injury compensation case. So we offered her a static ganglion block, and she could actually resume function, and we saw that her color actually resolved over a period of 2 weeks, and she could actually close her hands. When she came to me, she couldn't even move her hands at all, and was all stiff. Okay, things like knee radiofrequency ablation, where patients are too young for knee replacements, but they have osteoarthritis of the knee, or patients who still have pain after knee replacement, knee replacement surgeries, hip pain secondary to osteoarthritis, or sometimes you see the elderly with hip fractures due to falls, but they are not they are not amenable for surgery, not suitable for surgery due to many comorbids. We may offer radiofrequency ablations for them. Okay, so these are some of the sympathetic blocks that we offer for patients with cancer pain, pelvic pain, and abdominal pain. I won't go into much detail over this. And coccyx pain, I think some of you can see due to subluxation, coccygodynia, there's also interventional solutions for them. Okay, so as I said, the interventions list is not exhaustive. Those that I've shown are some of the common interventions we do, but at the same time, we don't just do interventions and then we tell the patient bye-bye, but we really follow them up, and we work with our physiotherapists, our allied health, on them getting back to function and quality of life. I think importantly, the main aim of all that we do over here is to improve function and quality of life, and to help them to cope with chronic pain. Okay, so interventions are just adjuncts to help accelerate healing and pain relief. Okay, we come to complementary adjunct therapies for pain management. Like I said, pain is not just about interventions, it's not just about medications, but we also rely on our friendly acupuncturists, our physiotherapists to help with our patients as well. So these are some of the things that we do offer. We do work with the people that we work with to help improve pain in patients. So acupuncture, I think you all will probably know a lot more, but it's based on the meridian therapy, and the acupuncture actually aims to restore the flow of qi by stimulating specific points. Okay, why I brought up this, because people will ask me, okay, so the Western practitioners will ask me, what does acupuncture do? I think it might be a placebo. I don't believe in meridian theory. There will be Western practitioners who ask me about this, and some of them really don't believe. But I do think that even World Health Organization recognizes acupuncture as an effective treatment for at least 28 conditions. And these are some of the conditions that studies have shown to actually help and work with. So acupuncture is part of a multimodal and integrative approach to a holistic pain management plan, and a non-invasive adjunct to a pain management plan. So this is some of the evidence for acupuncture in pain management. I won't go into much detail, but I would say that for objective studies and animal studies, where they do all the physiological, they do functional MRI and look at blood flow, with acupuncture needles, we show that there's increased blood flow, which help our body to heal. And so it also helps to reduce inflammation by modulating the mediator release at the site of injury. Okay, then the physiotherapists then will ask, what is dry needling? What is the difference between dry needling and acupuncture? So I would say that acupuncture follows very specific acupoints. It's based on the diagnosis and the pathophysiology of the condition that they prescribe a set of acupoints. One person with back pain may have different acupoint prescribed compared to another person with back pain due to the underlying factors and the yin and yang theory. Whereas for dry needling, is very targeted at the trigger points, at the areas of muscle tightness, knots, and the myofascial trigger points. So when the needle is stimulated, is placed correctly, it also stimulates the muscle to release and relax, and to release the knot and to relax. So personally, I've had both done before, and both have helped me with my pain. All of us will have pain here and there, and so yeah, I wouldn't really say one is better than the other. Okay, so these are some of the evidence for dry needling. I think most of the evidence are considered moderate quality evidence to at least for, and is effective for the very acute period of pain. It works less well when the pain is more than 6 to 12 months. Therefore, the acute effects of pain are recognized for dry needling. Okay, so same thing with dry needling. There's also the pain specialists, GPs, Western practitioners, orthopedic doctors may offer trigger point injections. It works on similar myofascial trigger points, but it's just that for trigger point injections, there's an injectate. However, interestingly to note that whatever they inject, whether it's normal saline, lignocaine, steroids, it doesn't help. There's no difference. So there's no study to prove that either injector is better than another. So in fact, there was a paper that recommended that maybe if there's no difference at all, we could inject normal saline. The aim is to actually dilute the inflammatory mediators that's surrounding the area of injury, so that it's not as painful anymore. And normal saline is not harmful. There's no toxicity. So that's the other thing. So this was in one of my previous presentations where the people were asking me what should I choose. So I think it really depends on who you see, the type of specialist, the type of person that the pain patient comes, and what they are trained in. I think in terms of safety, I would still say that these complementary therapies are safe in trained hands, and there is moderate quality evidence for these techniques, okay? Yeah. Okay, so then there's another thing called transcutaneous electrical nerve stimulation, which is TENS. What does it do? It works on the gate control theory, actually. So you would definitely know that there are pads like placed over there that generates this electrical current. So what it does is that it stimulates the A beta fibers to inhibit the transmission of C fibers. And it also results in the release of endogenous endorphins, which are opioid-like substances, so that it triggers our own innate pain relief system to actually reduce pain itself. Okay, so this is my last slide, I think. So I would just want to stress that the patient is not just limited to one practitioner, especially for the pain patient, because it's a multidisciplinary effort, a team effort, and it also involves the patient himself, how willing he or she is to work with us, to participate. If the patient is closed off to improving himself, like, I just want the specialist to treat me, I think the responsibility is yours to manage my pain, I would say that it's also a very one-sided thing, and the outcomes are usually not as good as if the patient is motivated. So yeah, that's my last slide, and I just want to thank you for, I don't know how much I do. Thank you.
Thank you, Dr. Chen. It's a very informative overview of what pain management is about. I know some of you have questions. I do have a question, but let's keep it to the last during the Q&A session. Let me invite Dr. Andy Hsu to share some of the very interesting view, I believe, with you on pain management as well.
Good afternoon, everyone. So it's with great pleasure to stand here in front of everyone today. I'm invited by Head Foundation, and I would like to express my appreciation to Director C.D. Leung and my good friends, Daniel and Ben. They are not here in the room. Okay, here is Ben. So my name is Andy. I'm a neuroscientist from Australia. I started a neurotechnology company in Shanghai, China in 2012. So what I'm going to show you today is to show you some of our latest research or our innovation in pain management, because pain management is a very small specialty in neuroscience. And I apologize because Dr. Diana did a fantastic comprehensive overview of pain. It's very academic. What I did, because I was told that we get general public attendees, so my talk today is very casual. Okay, so I apologize for that. So just a little bit of what I do. I do something called translational science or translational neuroscience. What is that? Most people have never heard that before. So I only have one job, which is make neuroscience understandable. Okay, so make people understand what we do. I want to make it, because it's so dull and dry and boring, so my job is to make it understandable, make it seeable, make it quantifiable or qualifiable. Okay, so I do a lot of research. So in the past 12 years, I've been going around China, mainly China, sometimes Asia, run courses. So we run workshops around China. This is one of our biggest workshop. This is not symposium, by the way. This is paid workshop. And we have over 1,000 attendees in China. Some people here have attended my workshop in Malaysia. We usually have a lot of attendees. We've done over 200 neuroscience workshops teaching people how to utilize neuroscience and make it fun. So I've been featured on CCTV. Last year, I was invited to this region. I was invited by Asian Federation of Sports Medicine to share what I'm going to share with you today on pain management. So I share stage with a bunch pain specialists, sports medical specialists from all over the world. And I was then invited by ISN, which is the National Institute of Sports Medicine in Malaysia, to share, again, what I'm going to share with you today. And then I had the pleasure to be featured on the Biologist magazine. And also, I am also very honored to call this guy my friend, who is the Deputy Prime Minister of Malaysia now, who represented Malaysia to join Singapore's National Day, Dato Seri Ahmad Zahid. So why this talk? Because I was so confused. My background, I started my career as a biomedical scientist, then I was a chiropractor. My dad is a GP, my grandfather is a GP. They love chiropractic as well. They forced me to study chiropractic. After being 10 years of being a chiropractor, I'm 45 this year, so this was when I was in my 20s. Then I realized something, that every profession had different opinion of pain. So if you look at all this long list of professions, if you ask them, doctor or whoever, why do I have such pain? No one will give you a unified answer, right? Everyone will say, for instance, I just realized we have a lot of TCM practitioners here. And you'll probably tell your patient that you have a blockage of energy, which is qi, right? So this is what TCM practitioners will tell you. But if you see a Pilates instructor, they do a great job helping people with pain as well. They'll tell you that you have a weak core muscle, right? You see a physical therapist, they'll probably tell you need to strengthen your muscle, either leg muscle or whatever muscle. You see a chiropractor, they will tell you your bone is out of alignment, which, by the way, I don't believe it anyway. I was in that for 10 years, but I don't believe it. You see a neurologist or psychiatrist, they'll tell you that you have anxiety. You need to take something called benzodiazepine. I'm not sure if anyone has taken benzodiazepine before. You see a GP, they will give you something called muscle relaxant. So why is it that everyone have a different opinion? I was so confused as a healthcare professional. I'm not sure if any of you is confused, but I was very confused. I had no idea what I was doing. So if we look at the history of pain, then we realize it's not just me. Everyone is confused. The Americans, they are confused, right? So they say the pain is one of the oldest problem in the history and no one understands it, okay? So when I saw this statement back in school, I wonder why. Because I always ask a question, why? Why this? Why that? So as a neuroscientist later on, I dive into research, which is what I'm going to show you today. But before we do that, I need a volunteer here on stage. Well, not on stage, coming down here. Oh, I need a volunteer. Can I get a healthy volunteer? I need 2 volunteers, one healthy, one unhealthy later. Okay, so 2 volunteers. Okay, come on down, please. And I want to show you something really interesting because most people have no idea. And in fact, most healthcare practitioners have no idea what we are dealing with. Okay, what's your name? Hey?
Jingyang.
Jingyang?
Yeah.
Jingyang? Jingyang. Okay, now, Jingyang, you're healthy, right? You're from Singapore?
Yes, I'm.
Okay, so now, can I have your permission to poke your hand?
Yes.
You sure?
Yeah.
Okay, now, so, and if you can, do this to yourself later, okay? And experience this. I'm gonna poke Jingyang's hand. He claimed himself being rather healthy, right? So I'm gonna poke. Now, what did you feel?
Pain here.
Okay, he felt the pain there. No, that's not what I'm looking for. What did you feel? Okay, well, again, Dr. Don actually talked about this, but you guys probably didn't pay attention. What did you feel?
No C-section here.
Yeah, don't talk to me about no C-section. I'm not trying to get fiery. Now, Jingyang, okay? Now, guys, poke your hand with a pen. Do that and tell me what you feel. What did you feel? You just feel pain?
A prick.
A prick? Is that all you felt? Now, poke yourself, guys. Now, you feel 2 things. Did you feel 2 things? Now, one instant sharp pain when you poke your skin or your body part. Then there's a dull, ongoing sensation, buzzing after that initial poke. Is that right, Jingyang?
Now that I think about it, yes.
Okay. Now he thinks about it, all right? So Dr. Donna talked about it. One is A delta, one is C fiber, but I won't go into the detail, but Jingyang, just do that again. Okay, I'm trying to be very gentle to you, okay? Now, sharp followed by a dull pain. So one is called acute pain, okay? One is called the chronic pain. Okay, cool? Everyone, guys, poke yourself. Thank you, Jingyang. All right, so if we can understand that, so what is it that we humans are struggling these days? Is it the first pain or the second pain? It's the second pain, okay? They have different neural pathways, okay? Dr. Donna talked about neural pathways, so I won't be going there. But it's a chronic pain that we humans, we have difficulty to cope. Now, when do we start to have chronic pain? Sir, do you have chronic pain? You do? How old are you this year? 60. When did you start to have intolerable chronic pain? Since 40s, okay. Madam, do you have chronic pain? Hey, you do? When did you start to have chronic pain? Quite some time. Like in the 40s or 50s? Now, in fact, right, I mean, she can't remember. And madam, do you have chronic pain as well? Not really? Okay, that's fine. In fact, chronic pain is a problem of getting old. Okay, I'm old. And when we were young, we never have chronic pain, right? We were able to bounce around, after we get hit or something, we fall down, we can bounce back straight away. But now when we get old, so chronic pain, the essence of chronic pain is part of getting old. And why we humans never understand chronic pain is because of this. I want to show you 3 diagrams, okay? Now this is the human life expectancy for the United States, China, and the rest of the world. Now what do you see? We never lived too long to experience chronic pain in the past. So as a result, for medicine, whether you're TCM or not, if you believe that our ancestors, our forefathers dealt with chronic pain in ancient times, think again. We used to die when we were 28 to 32. How can you experience chronic pain? The Americans are not much better. So the pain faculty in the hospitals, they are evolved through anaesthesiology, right? So they are, because the doctors or the medicines, they used to deal with acute pain. But now we are not dealing with that first type of pain. We're dealing with the second kind of pain, which is a chronic pain. And to experience that intolerable pain or chronic pain, doctors must have enough patients to study from. And to have that, we need to have enough population to live long enough for doctors to learn. And as we human as a species, we only live past, 40, 50 years old since 1970. So chronic pain is a big problem only in the last 50 years, just like cancer. Okay, and I believe, in my opinion, this is why we haven't really break through in pain management, because we haven't had enough experience in treating that. Okay, so I'm not going to talk about it. Now, so a very famous theory of pain is nerve compression. Have you heard that before? Right? You have heard that before. Now, most people believe in that. Now, I'm going to get all of you to stand up, please. Come on, stand up, please. And I want you to stand on one foot of yours. Flex your hip, stand on one foot of yours. Right? Okay, I want you to do that for 30 seconds. Okay? Or 20 seconds. Now, what do you feel? Do you have pain? Do you have pain? No? No pain, right? Now, what is it that you're compressing 50 kilos of weight on your foot, on the bottom of your foot. And why is it that you don't get pain? Is it because there's no nerve under your foot? Okay, sit down, please. Why is that? Is that because we don't have nerves? Why is that? Anyone? Now, people used to tell me because I go around, I've done this like public workshop or dialogue for many, many times. Now, people say, yeah, because we don't have any nerves at the bottom of our foot. So I asked the person, so when you go to a foot massage, what do you feel? I go, oh, ouch, right? They say, I'm not healthy. So we've got nerves at the bottom of your foot. So why is it that when we stand on our foot, we didn't get any pain? Why? So there's one very fundamental mind shift I think everyone needs to be aware of, is that pain is not a mechanical receptor. Pain is actually a chemical receptor, okay, the pain nerves. So Dr. Diana actually talked about it. She talked about substance P, inflammation and all that. So in reality, that means it's a chemical receptor. I know it's hard to understand, but experience this. So if you touch on your face, if you poke it, right, you won't have any pain. Does that mean there's no nerves here? No, you have nerves everywhere. If you have a condition called carpal tunnel, right, you push into the carpal tunnel, you will get numb. You don't get pain. If you sit on the toilet for too long in the morning, right, you sit there for half an hour and you get up, and what do you feel? You get pain? No, you will be limping and wobbly because when the nerve gets compressed, it will affect the motor function and the big sensory function. It won't give you pain. So one thing, obviously I know I can't convince you today, one thing you have to get out of is that pain has nothing to do with nerve compression, okay? So I have limited time, so otherwise I'll show you that. Actually, Alex, come on down here. Alex is a friend of mine from, 10 years ago? I went to your association and talked 10 years ago. I need a very young, skinny girl to come down here. So he thinks he's pretty tough, right? Come on down, a skinny girl. No one? Who's below 50 kilos? You look like you're skinny, come on. I might go, okay, I think I have 15 more minutes. I'll probably go 5 minutes overboard, hopefully. So I'll show you something, right? Now, what's your name? Joyce. Joyce, nice to meet you, Joyce. Now, can I get you to step on Alex's foot, please? He's a strong TCM. Okay, yep, that's okay. Okay, hold on to my hand and lift that leg up. How? Yeah. Okay? Okay, now, Alex, is there any pain? No. No, right? Now, what do you feel? Pleasure or pressure? I thought he said pleasure. Oh, finally. Okay. Pressure, right? Okay, now let's wait for another 20 seconds and see what happened. You guys have all experienced this before, you just don't remember. How about now, Alex? A little bit pain. Why? Why is it that when we compress on someone's body part, then we don't feel pain straight away? Is it because the nerves are conducting really slowly? If that's what you believe, poke yourself. You will feel it straight away. You wouldn't need to wait for 20 to 30 seconds. What do you feel now? More pain now? Yeah, no more pleasure, right? Okay, come on down. Thank you, Joyce. Let's give them a round of applause. So why? So as a neuroscientist, I ask why. Why is it that when our body part get compressed, we don't get pain? Why is it we don't get pain instantly? Why is it that we have to wait 20 to 30 seconds, then we get the pain? Why? I already told you the answer. Because pain is not a mechanical receptor. It doesn't detect mechanical changes. It doesn't detect pressure changes. It's a chemical receptor. Okay, we'll get to that later. And this is why if you stand on your foot, you don't get pain. And when you put a dumbbell on your foot, you will have pain after, not straight away, but in 20 seconds, right? And this is probably the only academic thing I have, right? These four receptors are mechanical receptors. And the top right-hand side, Dr. Dana talked about it. It's called the nociceptors. It's floating under your tissue, so it doesn't care about compression. It only tells you, it only sends signal to the brain when you are inflamed or when you have a change of chemical environment. So, okay, this is another academic. I won't go for that. So I call that a chemical stress. Okay, these are the factors that can cause pain. So as a neuroscientist, once I realized that, okay, I jumped out of my lens as a chiropractor for 10 years since I was in my 20s. Then I go, why do we have to manipulate bones when bone alignment has nothing to do with pain? Right? I only need to change the chemical environment to be able to change pain. Okay? By the way, I don't know who are chiropractors here. I have no intention to say you are doing something wrong. My intention is to share the science behind what we found. Okay, so I'm gonna do some live demonstration here. I need one person, one volunteer here with the longest history of intolerable pain. I can deal with anyone. And I'll show you how we can manage that, okay? Any volunteer that want to come up on the stage, maybe you have problem for more than 10 years or 20 years, and you have seen all the doctors around the world, because I deal with people like that all the time. Anyone? Do you guys have issues? Do you want to? Okay, you can do it. Okay, so you have a problem? Okay. What discomfort do you have?
I mean, if once I sit for half an hour, I will take like half a minute before.
Okay, so how do we measure that though?
Sorry?
How do we measure that? Do you have the pain now?
Yeah, a bit.
Okay, and how long have you had it for?
Maybe about half an hour ago.
No, sorry, how many years have you had it for?
I think should be 10 years.
10 years, so for 10 years he had this problem that if he sit more than 30 minutes, he will find it difficult to get up. Is that right?
Yep.
And you have the pain now?
Yeah, I mean, I can get up, but it's just uncomfortable.
You need time to warm up.
Yeah,
Because
so it's not intolerable, but it's irritating.
Okay, so anyone else? Okay, I don't want to pick the only one person. 'Cause I want you guys to pick, okay? Meaning that I don't know any of you, okay, except for Alex, okay? Sir, do you have any problem? No real problems. I thought you said you have problems since 40s. Now you have real problems because your pints had to come up here, right? Okay, sir, do you have any problem that's bothering you at the moment? Guys, like if you're a TCM practitioner, you probably will have some sort of discomfort in your fingers, your wrist for a long time from doing manipulation, right? As long as it's bad enough and people want to pick you, I will deal with that. Now, what?
I have a wrist pain that was sustained, I think, in my early 20s. So it took very long to get better. Now, sometimes when I carry something heavy, I will still experience it, but it doesn't give me problem day to day.
Okay, so he had wrist pain since he's in the 20s. How old are you now?
20s.
How old are you now? 23?
36.
36, so 10 years-ish. Okay, so you have it for 10 years, and you have it for 10 years. Anyone else? Okay.
Okay, so I used to injure my TFL, so it was.
You have injury at TFL, tensor fascicular tear. Yeah.
This part it was sore
Sore.
whenever I do lifting,
When-
especially squats.
Whenever he does squat, right? How long have you had it for? 10 years?
6, 7 years.
6, 7 years. Okay. Anyone? Anyone from this side of the room? Madam? Or Miss?
Injury.
You have a.
I had an injury.
You had an injury?
In my early 30s,
Mm-hmm.
and the pain is persistently there. So it radiates up to the neck area and even down to the arms, and sometimes even the eardrums and the back of my throat. And,
Okay. And the back of your throat.
it's something I live with.
Okay, something she lives with. All right, so we have a winner, I believe. So she has a physical injury. You never told us the injury is a physical injury, is it?
Yeah, it's because I was carrying something really heavy for long hours.
Okay, so have you had it for more than 10 years?
I would say about 8 years.
8 years, okay. So, all right, so we have, I need to respect the people there. Who do you want me to pick? I'm only able to deal with, because of the time restraint, I can only deal with one volunteer today. We have a beautiful lady who has problem since the injury. She has pain in the shoulder. I don't know where in the shoulder though. Around the shoulder, in the eardrum, in the neck, in the throat. Yes. And do you have it now?
Yeah, it's just there every day.
It's there every single day. All right. And we have also a gentleman that has problem getting up, getting raised. And we have a gentleman with wrist pain, and also a gentleman with pain in the anterior hip. Yes? Okay, so who do you want me to pick? The lady? Okay, can we all agree that we'll have the lady here as our volunteer? Okay, so can I come on up? Let's keep her. Okay, so hopefully we still have 10 minutes. Yep. Okay, so I'll probably I'll run a little bit late. Okay, what's your name?
Yeah, just push it on. Press the on button. Push it up.
Okay, right here. Yeah.
Hi, my name is Gretel. Gretel.
Gretel.
Yes,
Okay.
Hansel and Gretel.
So from Singapore, right?
Yes.
Yeah. Okay. So just tell us about. Just tell us again, share your experience of what you had, the injury. You mentioned you were carrying something, and what sort of pain are you experiencing, and how bad it is, and who you have seen, and what method of treatment you have experienced.
So I sustained my injury when I was in about age 32. I'm 40 right now. Yeah, so back then I was working as a medical rep in the hospital. So being a medical rep, I have to carry heavy materials to deliver to the doctors, right? So the whole building, maybe about 10 levels, I had to carry the heavy item for many hours. And eventually I felt some pain in my scapula. And while I was driving, I couldn't even turn my neck to check my blind spot. So the first thing I did was to see the general practitioner. And he gave me acupuncture, which is a strong painkiller. But the pain didn't go away. It felt better, but it didn't go away. And 1 week later, I could finally turn my neck comfortably. So the pain was just there through the years. And I saw TCM quite a few times. They did acupuncture, trainer, I do sign up for packages at the spa to get massages. I also tried to work out by exercising, doing pull-ups, strengthening my back and all, but the pain is still there. I even saw an orthopedic surgeon, and he said that I have some spondylosis in my neck, my cervical area. Yeah, so I guess it's a whole package, you know.
Whole package. Okay. Now, Gretel, where's the discomfort now? You talk about your throat, right? Is it on the left or on the right?
So it's from the pain, it's like a flower blossom, you know.
Okay.
Okay, so it
Blossom.
starts from the scapula.
Okay, can you show them where that discomfort is?
Yeah, so it starts from the scapula here. This is the main
Okay.
point, the middle of the flower, right? It will radiate all the way up into the cervical area and even down through the arms. And many times I feel a pain behind my eardrums and my throat, right? It's like the accessory muscles right down to the cervical area, it's aching.
Okay. Now, Gretel, let me ask you something because you describe a symptom of a large area, right? We have thoracic pain with scapular pain, shoulder pain. Do you have any discomfort here? No discomfort here? No?
It's like the very fine muscles are painful.
Okay, so pain in here.
Yes,
Okay, you should describe pain in the neck.
yes.
Right.
Like here, when you press on it, it's painful.
Okay,
Yeah.
when you press on it, you describe pain in the eardrum. Do you still get that now?
Yes, so while I'm seated, it's just
Okay.
persistently
No, on the
aching.
stage you do have that as well, right? No,
Now it's a bit better.
because you're talking.
Yes.
Yes. Okay. Now, out of all these, which one is bothering you the most?
I guess it's still the scapular pain and
Scapular
also
pain.
the cervical area.
Okay, I'll do
Yeah.
the cervical.
Yeah, because like you need to keep your posture right all
Sure.
the time, or like sometimes do a bit of stretches to
Okay.
release the pain.
Sure. And how, because you used to be a health rep, how on a scale of 0 to 10, 10 being the worst, what would you rate your cervical pain at the moment, or in your throat pain, in your eardrum pain?
I guess it's like regular 6 or 7.
Now?
Yeah.
Oh, wow. Okay, so she's been suffering this for a long time. Just on the right, not on the left?
Actually, the pain started on the right, but it really is to like the
Both
center
sides.
to
Yeah.
both sides, and even my left scapula it's
Painful.
beginning to ache over the
Sure,
years.
but right now, is it more on the right?
Right now, yes, it's more on the right.
And it's 6 or 7 out of 10?
Yes.
Okay, cool. All right, so I'm gonna, I asked that because now patients usually come up with a bunch of symptoms. So no, it's true. You usually come up with a bunch of symptoms, and they describe it as pain like a blossom, right? Flower blossom radiating from here to there. But in fact, it's a little bit like symptoms called sciatica, right? Now, sciatica is not one nerve's problem. Sciatic nerve innervates only all the structures below the knee. They don't innervate any sensation up here. So what I'm trying to get at is that I know you guys are mostly TCM practitioners. When we see a patient like that, we cannot think about one universal reason or cause that's responsible for all these problems. It's actually from 3 or 4 different nerves. So I'm going to show you something which will probably only help her partially dealing with all the discomfort here in the eardrum, in the throat, and in the neck, because these areas are from one nerve. Okay, so now, Gretchen, I'm going to spend 10 seconds or 20 seconds, and I'm going to poke one of your nerve points. Is that okay? All right, and it's probably going to be a little bit sore, okay? So I'll get you to sit here. Have a seat. And just feel your neck. You say your pain is about 6 to 7 out of 10. I'll just get you to turn your face to the right. To the right. Oh, wow. That's the most you can turn?
No, like how much do you want me?
Oh, yeah. Turn your face to the right as much as you can, and turn your head to the left as much as you can. Okay, so a little bit restricted to the right, that's fine. Look up as much as you can. Any discomfort when you move your neck?
No, it's okay.
Okay, when you look down, just look down. Okay, no problem. So now, can I get you to lift your shoulder up on the right-hand side? Yep, lift it up, up, as high as you can. Okay, good. Coming down. I'll get you to do abduction. Come up, lift it up. Okay, can you go up further, more? Okay, good, no problem. So you don't have any restricted range of motion now? Not much?
No.
Just pain, right?
Yeah, I mean,
Okay.
I generally exercise a lot.
You exercise a lot, but the pain's just there on the right-hand side.
Yes.
Okay, cool. All right, on the right, yes, just to make sure. On the right? Okay, cool. Can I get you to turn facing that way? All right. Just turn facing this way so everyone can see. Just turn facing this way a little bit, okay? Okay, I'm just doing a technique here. This is gonna be quite sore, sorry. Oops, sorry. Does she have any facial change? No? Oh, she is pretty good with pain. Okay. I'm sorry. Did I hurt you?
I can feel the pain.
You can feel the pain. Okay. Okay, good. Right. Sorry. I'll just clean your skin up. Okay. You can get up now. Now I just want. Oh, sorry. It's still a bit of cream. Okay. Now, just move your shoulder, move your neck. Do you feel any change?
I feel that the area here, the pain is, the area in the neck is, the pain is released. Yeah.
How about your throat? Feel your throat and your eardrum as well.
I don't feel the pain in my eardrum and my throat.
Not anymore? You felt it before, right?
Yeah, I felt it before.
Gone?
Yeah, suddenly it's disappeared.
Suddenly it's disappeared, right? How about the pain in here? You were talking about some discomfort here.
Yes, it's also gone.
Okay, now, so if you were to rate your discomfort now, the level of your discomfort, you were rating it 6 to 7 out of 10. What would you rate it now?
I guess about 5.
5?
4 or 5.
4 or 5? So some part disappear, some part still 4 or 5.
Yes.
Yeah?
So the scapula, I can still
Oh no,
feel.
I didn't.
Yes.
I didn't touch your scapula.
Of course. Okay.
Okay, so I'm
if
only-
you're
only-
looking at the neck area and the ear pain and the accessory muscles, I really don't feel the pain, so I get 0.
It's 0 now. Okay. Okay. So I told you there are 2 different nerves or 3 different nerves. Okay. So I'm just going to reveal. I'm not sure if I have the diagram here. So as a neuroscientist, thank you. Yeah. You guys want to know why? How we did it? It's interesting. I'm not sure if I have that. Oops. I mean, it works so fast. It works so fast that most people cannot believe it. So when I was speaking to Asian Federation of Sports Medicine, it works so fast on the stage. Those doctors from Middle East, they go, oh, did you put anesthetic on the person? But anesthetic takes longer than 10 seconds to take effect, right? We have effect straight away. And when, as a neuroscientist or health practitioner, you hear her stories like that, pain in the eardrum, you need to know what nerve innervates this sensation in the ear, which is called greater and lesser auricular nerve, right here, okay? When she talk about pain in the chest, it's actually called supraclavicular nerve. They are all cutaneous nerve. So what I did in a nutshell is that I desensitized a neural point here called Erb's point. Because the Erb's point, when it's sensitized, it will amplify all the discomfort in this region and send the signal to the brain. Not acute pain, but chronic pain called C fiber. So I desensitized C fiber. All of a sudden, her discomfort for 8 years were gone. Okay, so I know it's hard to believe, but this is what I do. This is what I call translational neuroscience. Because we all study so much, right? But why do we study so much? We need to help people. Okay, so now I had the pleasure to, when I only landed in Singapore yesterday, I had the pleasure to visit a really cool place called Nova Health. And Nova Health has this futuristic AI robotic machine. And they're really cool because I'm an AI guy too. I'm an engineer too. I'll show you I don't have my lab's picture, but we do brain tech too, right? So when I saw this, I was like, wow, this is really cool. What they do is that they have an AI, they use machine learning technology, and to have this machine arm to massage or to do tuina on a human spine. And this is Ben we're looking at. This is Ben lying down, so that's his sexy back. And with the machine learning, he can feel the rebound, the stiffness of a muscle. Then you can quantify and which part of Ben's spine has issues. So I went there yesterday. This is Ben's spine. You can see his spine is a little bit tight on the right-hand side, indicated in yellow. And for his middle back, he's got red on both sides, indicated in red. And then for the lower back, he's got problems on both sides as well. So in neurology or neuroscience, upper back controls your heart and your lung. Middle back controls your stomach, your internal organs, and your kidneys, and your small intestines, and organs like that. So we know that Ben doesn't have a good digestion, okay? Well, from neuroscience theory. And lower back controls your pelvic organ. So I don't know if you use the pelvic organ enough, but so he's got problems here and there. And so the machine, this is a really cool machine. So it actually can do diagnostic tools. So we know that the patient has that. So what I did yesterday is that I desensitized Ben's lower back for each spot for about 10 seconds, all together for 1 minute. So straight away we get a machine to check it again. Now he doesn't have the problems anymore. A little bit like the beautiful lady just then. All these problems are mysteriously gone. Okay, and by the way, this is a really cool machine. They have 11 clinics in Singapore. Me and the Deputy Prime Minister of Malaysia, they want me to open a few clinics in Malaysia. I'm hoping we'll be able to use this in the future as well. But this is the fun side of neuroscience. We can modulate the fiber, the nerve fiber. We can modulate pain. We can modulate discomfort. We can modulate muscle tone. Okay, so that's what we did. And anyway, that's all I have to share today. And please follow me on LinkedIn or TikTok. I have a TikTok channel. I started 3 months ago. I have 60,000 fans. But I do neuroscience podcast, not this kind of stuff. Yeah, I just do, I think that's all, right? So thank you, everyone.
Thank you, Professor Hsu. We have about 20 to 30 minutes of Q&A time. Let me invite Professor Hsu and Dr. Chen to the front. And please, if you have a question for them, please raise your hand, tell us briefly who you are, and ask a question. And please limit your question to one at a time so that everybody has a chance. Thank you. Or maybe I should ask first. Okay, both of you talk about pain as maybe as a warning mechanism for us to be aware of some problem with parts of our body. So if we are using medication or some other ways to reduce or even to eliminate pain, how do we balance between pain and losing that mechanism, the warning mechanism of our body?
I think when we manage pain, we don't just focus on symptom reduction in terms of reducing pain. But often we want to look out for red flags, which means that the pain may actually signify something that is more sinister, more serious, that is ongoing in our body. Maybe I talk about an example. Recently I saw a 34-year-old female, and she presented with very severe back pain. She was first seen in the hospital, and because of her age, they took an X-ray and everything was okay. So they prescribed her with some painkillers, simple painkillers, and she went home. 2 weeks later, she came back with severe back pain that is not amenable to even simple painkillers. And that was when something lighted up in the hospital. And we only knew about her and her symptoms like at the second time when she decided to find us somewhere else out of the hospital. And we did a scan because it was very unusual for someone at her age to have such severe pain. And then we found out that it was metastatic breast cancer. So which means stage 4 breast cancer that has spread to her bones, causing all the back pain. So I think pain reveals itself in terms of red flags, but at the same time, whenever we see our patients, or when you ask yourself the symptoms, sometimes you might say that, oh, it's just simple ache and soreness. I don't think there will be anything wrong in it. So you self-medicate and the pain goes away. Usually when the pain goes away, it does mean that there is some healing inside your body. But when the pain does not go away, then light bulbs need to ring. And it's not like you continue to tahan the pain or to tolerate the pain, but to really seek someone for help. So with that lady, because it was cancer and cancer that has spread, it was only when it's the whole thing already. So it means investigations, working up, and then managing her pain, which required very strong painkillers, which were only we could prescribe. And the strong painkillers at that point in time, the aim was to relieve her of her suffering, right? So, so I think the balance is that as medical practitioners, we know when like a pain is more than just a pain, just a simple pain, but it signifies that something is wrong in the body. Yeah.
Can I just add to that? So the theory of pain is a protective mechanism. It's actually it comes from a lot of medical textbook, which is true. But what I would like to emphasize is that there are two types of pain. One is the acute pain, which means that when you get the tissue injury. One is the chronic pain. And the reason of chronic pain in neuroscience is for you to solidify that memory so you don't do something silly again, right? So when we step on a nail, that will instantly reflex and jump off, right? This is the protective mechanism when we touch a fire. This is the acute pain. This is not a chronic pain, right? So for us, I believe that when we manage, like for instance, when we have Duke-NUS, when we have acupuncture or whatever technique, we will help chronic pain. The problem is the chronic pain, it's not acute pain, right? So we are not going to deprive the person's ability to sense acute pain, right? And exactly like what Dr. Diana said, if the pain is ongoing, it means something is going on. Because Dr. Diana also talked about this, it's in one of the first few slides, International Association of Pain Studies. They classify chronic pain being 3 months, any pain longer than 3 months. And the reason of why they do that is because in 3 months, if you have a tissue injury, it should heal by 3 months, right? So that's what we need to be careful of. Don't do something stupid again. So by 3 months, it should go away. Just like when we were kids. You sprain your ankle, you put it in a cast, or you break a bone, put it in a cast. After 3 months, usually we can get up and running again. But when we get old, these kind of problems tend to linger for a long time. And I don't believe that has any beneficial function to human other than giving us misery when we get old. But the protective mechanism is still there, right?
Okay, so yes, then we go on to that, right? So I believe that chronic pain is maladaptive response, is a maladaptive response to pain.
Yes.
Yeah, so when it becomes chronic pain, it means that if all the investigations have been done to rule out very serious injuries and it becomes chronic, it also means that your body has gone into this what we call sensitization. Your nerves are a lot more sensitive than ever to actually feel that type of pain. And so if I'm sure you've come across people who are like, oh, I have a lot of pain. Everybody tells me that I'm crazy. Yeah, so, and then you look at the underlying, I'm not saying that patients who have chronic pain are all crazy, but it's more of like how we respond to pain. And then this requires a re-education on how we manage our own pain at the chronic stages.
In the hospital, if a patient is already on morphine due to chronic pain, what other method maybe Dr. Andy can share to help to ease the pain?
It's a hospital question. You answer first.
Yeah, I mean the patient is already on morphine.
Already on morphine?
Yeah. So what other alternatives? In terms of just now you did a massage to help to relieve the pain.
It depends on the pathophysiology, the pathology of the problem of the pain. Because you say in hospital, did the person have cancer, or did a person, why is he or she on morphine? Cancer, right? So, and did he have chemotherapy, or what sort of cancer was that? Because what I did, right, the technique I did will not help primary cancer pain. Primary cancer pain meaning that a pain originated by the cancer cells itself. And there are also secondary cancer pain, so meaning that pain is related, but then it's probably not from cancer itself. So from my experience, and because I have probably 5,000 students in Asia who practice this technique, we can help pain that's indirectly related to cancer. For instance, you have a cancer, you cannot walk as well, you have to be bedridden for a long time. That sort of pain we can help. But for cancer, primary cancer pain, such as what Dr. Diana was talking about, women who have breast cancer stage 4 and have thoracic pain, I don't think what we do can help because they have acute pain, ongoing pain all the time. My technique only helps with chronic pain who have what Dr. Diana said, maladaptive pain system, okay?
Although the question is not directed at me, but maybe I can talk a little bit more.
Yeah.
So when the patient is on morphine, generally they have very severe pain because opioids are generally only recommended for chronic, for cancer pain, and for chronic non-cancer pain is actually not recommended. We have a opioid crisis in the West because it was prescribed out of due to abuse lah. So it was like anyhow prescribed. So then, but I've also managed a lot of cancer pain where we could actually help to wean the doses of opioids, which means that usually sometimes they have so much pain that we have to keep increasing the doses of morphine, and that's when the pain specialist comes in to try to reduce the doses of morphine so that they are a lot more alert, they can live a much better quality of life. And I think I've said in one of my slides, sometimes we either add on different type of pain agents to target different receptors in the body. Secondly is intervention, for example, like the intrathecal pumps or even topicals to help temporarily relieve the pain. We know that cancer pain is not curable. The cancer cells are the ones that, the pain is due to the cancer progressing, and it's usually in the later stage that the patients have pain. So as long as there is ongoing pathology, as long as the cancer cells are ongoing, multiplying, and they're compressing on the organs in the body, or they are attacking the nerves in the body, we can only symptomatic relief. And that's why I think morphine was used as a strong painkiller for cancer pain management.
For anything, if a person has pathology-induced pain, you should see someone like Dr. Diana, right? So she has a diverse toolbox that can deal with each sort of pain. But my job is to help someone like her who has scanned, seen a lot of doctors who they say, I have no idea what's going on with you, and they have such a long time. And the doctor go, I can't help you, but you don't have pathology. That would be our job. And even if you were a TCM practitioner, that should be your job. We should leave the ones that have cancer and have to deal with pain to someone like Dr. Diana, and that's her specialty. So we really need to differentiate between the pathology-induced pain versus something like chronic pain. Yeah. Because it's ongoing, right? She said it's ongoing metastasis affecting the pain. There's a gentleman in the back.
Hi, my name is Ron. I'm actually a therapist, and sometimes I have clients with chronic pain issues as well. I think my question is, how does psychotherapy fit into this holistic management, the case management for a client with chronic pain? Or I think the more interesting question is, sometimes do you take on this role, like an impromptu therapist role, especially when Dr. Diana said, in the re-education of what pain management looks like for them?
I can demonstrate psychotherapy on stage because it's part of neuroscience, but I want Dr. Diana's opinion first. Yeah.
Psychotherapy definitely play a role because, like I said, everybody approaches their pain symptoms differently. We talk about negative coping strategies to pain. Okay, I'm sure you have heard about that. There are a lot of skills in the there are a lot of skills we've used. One of them is pain catastrophizing skill. So we know that the higher the score, which means that the patient actually catastrophizes about the skill, her pain. For example, I will never get better. You think about the negativity. I will never get better. It's going to affect me. Don't want to go out. I think that I'm going to die and I don't want to live with this pain anymore. All these are negatives. So when they are in these negatives, the emotional center of the brain, the amygdala and all these parts of the brain, I'm a bit academic now, it actually perceives the pain as something that is doomsday. Okay, then then it affects them. And so every day they wake up, they anticipate the pain. I'm going to have pain today. I'm not going to be able to do anything today. I don't want to go out. I don't want to see my friends. I don't want to participate in any activities. Our job, or my psychologist's job is to actually retune this whole part into something that is optimistic. Yes, I have pain, but I can live a normal life like people. I can function. My pain will go away. I can live with some baseline pain. You think about what is this difference in the perception, and then we talk about distraction therapies as well, getting on a hobby, distracting ourselves from everyday fixating ourselves on that we are having this pain, and distracting ourselves from other and to find other enjoyment in life. When we have things that we enjoy, the endorphins that we have, all the medical, the neuroscience, sorry, I can't remember.
Endorphin, dopamine,
serotonin,
serotonin.
Everything is like increased in our body. And then these are also act as like opioid systems in our body, innate opioid systems which actually help to alleviate our pain. So it's all, so we talk about cognitive behavioral therapy, we talk about mindfulness-based stress relaxation therapy. And I think recently there is this therapy called mind-body, why we tell ourselves that our body functions as a whole, our pain is also a manifest, and how we can actually control what we feel about the pain. So I think all these changes in how we perceive the pain actually helps the patient to view the pain in another way. And our brain is very neuroplastic. I'm sure Dr. Andy will be able to say. We have seen that patients who undergo CBT, MBRSR, there are differences in how, when they do the functional MRI, how the brain lights up. And we know that this actually signals improvement in pain experience.
I just want to say I'm so honored to share stage with Dr. Diana. She has such a comprehensive view of pain, because I do this kind of stuff a lot, especially in China. I go to top hospitals, top medical symposiums. A pain specialist is usually very focused on one single aspect, but she has such a diverse knowledge even in psychological pain, so pain management. So I'm quite impressed. Sorry to say that, but I'm so honored to share stage with Dr. Diana. But Ron, can I get you to come down here? I'm going to show you something interesting because Dr. Diana talked about mind-body relationship and awareness, right? Because in China, since 2018, there's a concept of somatization happening, and so I want to show you that. But because doctors are not very good at doing what we do, and I need to show you that. So do you have any discomfort? And I want to show everyone. Do you have any discomfort anywhere?
This today only, I just got a bit of soreness in my calf.
Okay, soreness in your calf, your calf on the left, right?
Yes.
Can I get you to bring your legs together? Sure. Yeah, can I try to get you to, don't move your legs, don't move your feet. Try to touch, bend forward and try to touch the ground for me. Okay, you can touch it right now. Try not to bend your knee, okay, yep. Oh, okay, you can see he almost touches the ground, right? Okay, now, come up. Now, do you feel any tightness in your left calf?
Bit lesser.
You feel something right now. Is your boss here?
My boss?
Yeah?
Not right now.
Not right now?
Yeah.
So you're not related to anyone here?
Not exactly.
Okay, now, can you think of an unpleasant memory at work? Quite a few, right? Now, close your eyes. Now, bring your feet together. Think of an unpleasant memory. Maybe it's your boss, maybe it's your colleague, maybe it's your mom, right? Or grandmom. Okay, tell me when you're ready. Now, can you think of that scene that you were getting abused or scolded? Maybe he has a healthy mind, but I want him to experience because he's interested in that. He's interested in this area. Now, you're thinking about that now? Okay. Now, do the same thing. Bring your feet together. Okay. Think of that unpleasant memory and trying to bend forward with your eyes closed. Go. Okay. What do you feel? Ron? Okay. Keep your. Yep. What do you feel, Ron? Can you see his flexibility decreased? And what do you feel, Ron? You can come up now.
The pain from the bending over, like, overrides the discomfort from thinking about the memory.
But then you were all we did is we trigger him to think of something unpleasant. Now he has discomfort, the pain may be a little bit more obvious, and your range of motion decreased. So this is what Dr. Diana was talking about, how mind can affect the body. Okay, so obviously this is something I think very neuroscience, very scientific. People who don't understand psychology doesn't understand how this works. They think, they just shrink lah, right? Do we call them shrink in here? Because in Australia we call them shrink. But then, anyway, but this is so real though. Your mind does affect your body. So you need to see a psychologist if you have to. No, sorry, not you. No, not you. Your patient. Yeah. Okay, thank you, Ron. I hope that helps. Yeah.
No, but it is true because I also have some chronic shoulder pain, and I know that whenever I'm stressed, and you know how doctors can be actually very, very stressed or overworked. There was once when I did fellowship in Australia as well. I did my pain fellowship, and then there was something that was very stressful. And actually, my husband next to me was like, I could literally see your shoulders tense up, and I immediately felt pain over the shoulders. So actually, really stress, negative thinking, mindsets, and all these things really affects how relaxed your body is and how the pain is being perceived.
Yeah. You had a question?
Hello, my name is Jing Yang and I'm a TCM practitioner. My question is with regards to the technique that Professor Hsu did on Greta just now. It is a hypothetical question because Greta didn't present with a restriction in her range of movement. So my question is, should she have a restriction in her range of movement? Would your technique have improved that as well?
Yeah, easily. So the course I didn't mention because I didn't have enough time. So I've done this workshop just in Malaysia itself at Institute of National Sports Institute ISN, I've done 14 times in the last 20 months, training physical sports science doctors, therapists, to do this, to improve their performance, and also to deal with pain. Because, again, this come back to Dr. Diana and CD Leung, Director Leung's question, that pain is a protective mechanism, right? So when we have pain, or when we ever experience pain in the past, our brain wants to protect ourselves. The first thing the brain will do is to restrict your movement, right? So I have pain here, your shoulder will not be able to move as well. So and that's actually coming from C fibers, which I talk about the chronic pain. So what we found is that once we desensitize, so Dr. Diana talked about central sensitization, peripheral sensitization. Once we desensitize the nerves, the brain doesn't think it's a threat anymore. So your range of motion improved. Okay, there are a few students of mine here, the beautiful lady here, she attended my class as a patient, I know, traveling from Johor Bahru, yeah, and she's a cook. And she had pain in her arm. Is your arm better now?
Very big better.
Yeah, she's, for sure. Yeah.
20 to 30%.
Still have 20, but she had pain for like 20 years. I only treated her, well, not treated her, I only used her as a demonstration once, just like what I did for the lady over there. So, you know, we believe the pain is overcomplicated, some pain are overcomplicated, and we can help them in the easiest way. And this is why I need to share this knowledge. And it's just a protective mechanism, right? Yeah, I hope that answers your question.
I have along that line, I have a question. Just now you demonstrated the technique, Professor Hsu. How sustainable is the cure? Or, in fact, I should ask the lady who participated in the demonstration. Is the pain coming back, or is it still okay?
Right now, the pain is still gone. Yeah, but it feels weird, you know, because I'm so used to the pain.
Yeah. I've done this around the world. Most people, when they see it, they can't believe it because everyone thinks pain is so hard to manage. They'll go, will it come back in 10 minutes, 2 hours, 2 days? If you're lucky, it won't come back. Well, it will probably come back partly. Sometimes it takes maybe 5 treatments. I wouldn't say, maybe for the lady, I think I did 1 or 2 for you because she had the pain for 20 years and she's a cook. She has to cook all the time, holding the pain, right? So she has that repetitive injury and she still cannot retire. She said, I have to go home and cook. But for someone like her, she's already exercising, she has a good lifestyle, she doesn't have restricted range of motion. I think maybe her pain is just like what Dr. Diana said, is a maladaptive problem. So hopefully, maybe you can talk to Director Leung maybe in a month and tell him that whether you still have the pain or not. But again, I didn't work on your middle back, okay? So don't blame me if your middle back gets worse.
我可以讲华语吗？
可以，
可以吗？
可以，可以。
可以哦。Sorry 啊，Dr. Annie 啊，我是在吉隆坡，他帮我做这个手。其实我这个手是不能拿上来的。那天他帮我做了，他帮我做第一次的时候，我的手就可以拿上来了，到现在还可以拿上来了。但是有时候因为我一直做工嘛，都是会痛的这边，不是每一天痛的。有时候我有做工的时候啊，第2天我就会痛，过后我就不会痛。其实啊，几号？4号、5号，我的外甥啊，那个董，他说你可以来嘛。Dr. Andy 有在哦 ，Andy， 我讲哇远的，但我跑到吉隆坡，他跟我讲可以，你可以到新加坡去。新加坡，我的孩子在这边，这个我大孩子，我就跟我孩子讲，可以，我就跟Dr. Deng讲我可以来，所以今天我很高兴我遇到他，所以我要告诉大家，这个是nerve 神经啊，是不是？
C5 yeah.
这个的问题嘞，我跌倒我touch， 因为我跌下去，是因为那边好像有一个线这样子，凹凸不平的路，那我又没有看路哦，我是看前面哦，突然间踩空下去，我就跌下去1年后嘞，跌下去的时候我有去做 X 光，什么我都有去做了，但是还是不会好，但我就是咚就跟我讲说，来，然后Annie 有在，然后他是专医这个神经的。
哦，没有，神经的，好像有神。
教课老师。
对，
教课老师啊，我就很幸运我会遇到他。
Thank you。
他可以帮到我这个手超好。你看我再拿上来给你们看，直的。本来我是这样子的了，不能拿上来的。
好久了 ，half a year， 半年了吗？还多久了？
到现在。
是什么时候？我什么时候遇到你的阿姨？
应该是6月吧。
6月，是3个月呀。
Before 那1年呢，我都不能够拿起来的。那我今天很高兴，我来见他，谢谢啊。
我的 my job is not treat people. My job is to teach people. Yeah, I used to be a chiropractor, and I have quite a few centers in China, and now going to have one in Kuala Lumpur. But I don't want to see people because there are so many people who want to see me. So I rather no. But seriously, I want to teach people so you guys can help more people, right? So hopefully you guys all learned something today. And in the future, I believe in robotic can really help people. That's my belief.
Hello, I'm Joanna. I'm actually a TCM practitioner as well. I'm from AI Treat Emma and Noah Health.
Oh.
Yeah.
Oh, Joanna. All right.
Yeah. So actually, I'm also a TCM practitioner, right? So a lot of patients actually comes to us, especially when the pain is unbearable. So it's usually during the acute phase. But of course, in Singapore, we are in private practice, so it's really all out of pocket. So our usual practice is like patients come in once a week or twice a week for acupuncture. All right, then we may use combination treatment. But my question is like, so this is the acute phase, and of course when we were in our China practice, then it will be more aggressive, like 5 times a week acupuncture. So that's acute phase, but I also heard about the baseline pain. You may just live with a baseline pain. So in terms of your practice, do you believe in preventive treatment? All right, like do we then it could be something that in our practice that we can also look at, like preventive treatment once a month acupuncture, then based on TCM practice, right, is to 通经络, right, and improve circulation. So I'm not sure in your practice, how do you see this part of things?
You're asking me?
Both.
Okay, I just give an example. For example, if someone comes to me and tell me that initially they have this maybe neck pain, I did an MRI and shows a disc bulge and a facet arthropathy. I gave her some medications. The pain went away in about 2 weeks. She said, "Oh, my pain is gone." Am I going to preventive treat it like with an intervention, with an injection? I'm not. Okay, because the MRI will show up a lot more degeneration than what we actually feel. I will always tell my patients I may have the same, if I scan myself, maybe I will have the same pathology as well. But yes. I'm not going to treat it aggressively. The reason why is I think, it's different now. Western medicine and TCM is different because TCM there's this whole theory of also improving health, overall health, improving 经络, I mean, all these things. So some people do go for maintenance acupuncture treatment, I know, because my dad was an acupuncturist. I mean, he's an acupuncturist, but now he's not practicing anymore. I learned acupuncture and I do sometimes do it on myself. It's really, we look at a lot of different factors. Number one is affordability and sustainability. If the patient is very rich and you say that, oh, I just want to go for this maintenance because 我要长生不老 and all these things, right? Okay, go ahead by all means. Is it going to harm you if the treatments are not harmful? Just go ahead. It's just like I'm taking supplements, right? To let's say vitamins and all these things to prevent all this. This is preventive health. And there's a lot of talk on preventive health. So it's all about affordability and sustainability and risk management. If something that is not going to harm you, I would say just go ahead. But if it's going to cause harm, then I will weigh the risks and the benefits of the treatments, for management. Yeah.
Yeah. I'm a big fan of preventive health care. I'm not sure whether this is, what I'm going to say is scientific, but for instance, Ben had a checkup at the clinic, and Ben didn't have any symptoms, right? He didn't have any pain, but the muscles were tight. And I believe when they get worse, eventually he will have some sort of issues, or it's already affecting his internal organs not doing well. Usually, and again, like what Dr. Diana said, pain is a multifactorial kind of experience and sensation. So when Dan argue with his friend or girlfriend, then all these symptoms will come up. But so I'm a big fan of it. So I believe, really the general public have no idea what our body is like. So I think everyone should do something, have a healthy lifestyle. And myself, I preach what I say. So I'm 45 this year. When I was in my 20s, because I didn't get my health answer from chiropractic. So before I did neuroscience, I studied this discipline called functional medicine. Is it practiced here in Singapore? Functional medicine is a branch of mainstream medicine. It looks like your blood report and tell you what to say. So I'm a practice functional medicine myself, and I preach it myself. I check my blood, and I eat whatever that can help my blood to look better. So I spent a lot of money in the last 20 years on antioxidants, on detox here and there, and I'm really very, very energetic, and I exercise as well. I do 155 minutes of 70% maximum heart rate exercise per week, advised by WHO. Because I think if I was to tell patient that, hey, you need to get healthy there, and I'm a fat guy, so no one would believe me. And if I was to help people's brain, I need to have a good brain too, right? So, and I do weights as well, because in the last 4 years, now there's a trend of people keeping your muscle so you can age slower. I'm trying to be 长生不老. Yeah, 长生不老. I'm trying to practice that now, just to age slower. So I'm a big fan of your work, and I believe those machines can really help preventing a lot of problems in the future. But again, that's my belief.
Okay, let's take one more question before we end the session.
Hi, my name is Isaac. I'm a neurophysiotherapist by training, but I'm doing more research work now. So I really want to thank Dr. Diana and Prof Andy for sharing today. I think I really learned a lot, and I'm enlightened by, I'm quite happy there's a room full of multidisciplinary teams here, all related to pain. So my question is actually directed at Prof Andy. I'm trying to reconcile something that you were saying about pain, especially chronic pain being a chemical response, right?
Yes.
So when you were treating Greta just now, I'm trying to reconcile whether what you did, was it something in the crib? I was trying to see whether I missed out something. Was there something chemically that happened?
Yeah.
That when you were desensitizing that nerve?
Yes.
Right? So was it, so I was trying to reconcile, was it pressure that you desensitized? Was it something chemically that happened? Yeah.
All right.
So, yeah.
So I'll answer that. So like I say, it's not it's not acute pain. First, I need to differentiate acute versus chronic, right? Greta says she had problem for 8 years, so I know it's chronic for sure. She says she's seen a lot of people already. I know the pathology is probably not there except for part of spondylosis. But like what Dr. Diana was saying, that you will have, if we have the scan, we all have spondylosis, right? So long story short is that I know which part of the nerve are responsible for her symptoms. In about 2018, I was very lucky because I've been studying neuroscience for a very long time, up right now maybe 18 to 19 years. And I always trying to crack mysteries in neuroscience. Pain is being one of them. I think I've cracked a lot of neuroscience. If I was to publish math study papers, I might win Nobel Prize, in my opinion. But we cracked a secret formula that I was like, oh, wow. If pain is a change of chemical environment, for one, why do we always trying to use physical modality trying to change it? Okay? So physical modality to help pain is because physical modality can help the, for instance, maybe blood circulation, to change that physical environment. But for me as a scientist, I think a chemical problem should be chemically solved. So for years, I've been trying to come up with a solution to see, because there's a lot of like TRPV receptors, ASIC receptors, a bunch, right? And traditional topical agents, they usually have menthol, something called menthol inside. So it will give you a cool sensation. I'm not sure if anyone has experienced that. That cool sensation will block your sensation of C fibers. So usually what you experience is that once that cool sensation is gone, the pain will come back. I'm not sure if anyone has experienced that. So for Greta, for her case, you didn't feel any cool sensation, right? There's no sensation. So for one, when I was modulating my formula, I know I cannot mask people's pain, right? So I need to solve it. So we discover a formula, and it's actually a ratio of different natural ingredients, because I want to be natural too. I don't want to hurt people, right? That can actually change and neutralize that chemical environment. So when I first did that in Malaysia, Institute Sugan Nagala, National Institute, they took our thing to the 188 stimulant check. So we all passed that. There's nothing bad, but then it's just a secret formula we found. It's quite complicated in neuroscience, but it's a chemical formulation we have that can just change pain like that, and make it so easy. So I'm not sure if I answered the question, but yeah. Yeah. So chemical problem. No. Chemical problem, chemically solved. That's my opinion. I'm not sure of Dr. Diana's opinion.
I just want to ask, if it's not a cutaneous nerve, if it's a deep nerve, a deep pain or dull pain, would your technique still be able to treat?
And this is what I found. Oh my God, I think we're over time. If you have internal organ pain, right, this is what we found so interestingly. Yeah. And I think this is why TCM and chiropractors have done this a great job. So for instance, do we have any stomach pain here right now? If we have stomach pain and menstrual pain, right, dysmenorrhea, they feel the pain inside. But I found that they are actually the pain sensation are actually amplified by their somatic nerve, meaning cutaneous pain. And the reason how we found out is that, you see, I've seen women having a big cyst taken out, maybe this big, right? And they never felt a thing. So, meaning that our internal organs are not very sensitive to pain. It usually has to rely on external sensation to tell us what we feel. So, I mean, we're running out of time. I know I don't want to rob her time because I know she has to go at 4 o'clock. But afterwards, if you have any internal organ problem feeling deep, right, we can desensitize on the cutaneous nerve, innervating that part of the skin, and your pain will go away as well. It's so cool. But we'll see. I don't, she needs to go.
No, it's okay.
Yeah.
Okay, we have to end the session here because Dr. Chen has to go. But I believe Professor Hsu can stay a while. If you are too shy to ask questions just now and you want to ask him personally after this. Again, thank you all of you for coming. I hope we had more people here today because we did learn a lot. It is exactly what we are trying to do at the Head Foundation. We try to put different solutions together, whether it's east or west, because our body is our body, right? It's not the east body or west body. The more solution we can put together, the more problems we can solve. That's one of the things we are doing, for example, is to get trainer accepted, in Western hospitals like SGH or even Mayo Clinic in the US. In fact, we are trying to work with Mayo Clinic to get trainer somehow FDA approved. Right, so these are the things we do. Stay tuned. Go to our website and see what we are doing. And Lastly, I'd like to thank Dr. Chan and Professor Hsu again for the talk today. I also wish to present a small token of appreciation on behalf of the Hay Foundation. And thank you all for coming.